Welcome, everybody, to the Sapien podcast. Exciting episode today. We're going to be talking about hospice care, end-of-life care, geriatric care, and sort of that whole world of medicine that I have such a strong passion for. I have Dr. Petra Davelaar with me today. She's a naturopathic physician that provides really holistic care for her patients. And we've shared a number of cases over the last few months that we'll share with you guys. And the idea of the podcast today is really to answer some of the most basic questions about hospice and end-of-life care, but also kind of give you guys an insight into what a primary care physician like Petra would be thinking about and asking about. So, Petra, thank you for joining me.
Oh, thank you so much for having me, and thank you for allowing me to pick your brain and help understand what it is that you do and how you can be helpful to a lot of my clients.
Yeah.
One note, I don't provide primary care.
Oh.
In fact, I provide all sorts of other care, but not primary.
So how do you consider your work? Like as a guide through the healthcare system?
Yeah, very much. Indeed, that's a great way to describe it. I try and have my clients, I help them collect, select, and navigate through the entire process and help them find the best, most appropriate treatments for them so that we can be as efficient and mindful as possible based on their preferences, really.
It's so important because the healthcare system is so hard to navigate, right? And I think that's where we connected, is even yourself had so many questions about hospice and end-of-life care. And it's really common. And so why I try to do the podcast is to try to get people to have a starting point. And I think that's what today's about. Like, for someone who's listening, if you have a family member or even yourself going through some really heavy medical stuff, at least you can learn about what your options are when it's that time.
Yeah, it's so important. And there are, unfortunately, in some cases, we end up in a place where we know there is no turning back, and that the decline of the client, the patient, is to such an extent that I think it's really important to shift gears and honor that part of that life phase as well. And I'm sure you have a lot to say about that, right?
I think honoring is a good word. I think so much of it is shrouded in fear and shrouded in sort of, let's defer that conversation. Let's defer that end-of-life talk. Let's defer until we're at that final step. And oftentimes that doesn't allow for appropriate navigation of all of these resources available to people. And also spiritually and emotionally, if you wait until the end, it's the most challenging time. You want to prepare.
Yeah, so can you expand on that a little bit? I think it's so important. And yeah, go ahead. Yeah.
Like, it's called advanced care planning.
Yeah.
So advanced care planning is a medical term where we discuss the goals of care for someone. Advanced care planning actually started becoming a billable procedure right around when I graduated residency. I think it was like 2016, 2018, something like that. And I was excited about it because it's something that I did in residency. I would always talk to families about realistic prognostication. What frustrated me the most in my training was doctors are good at being aggressive and doing 100 moves to accomplish symptom management or accomplish some kind of medical intervention, but they're bad at having the uncomfortable conversation. And that's not to knock physicians. First of all, there's not enough training. Secondly, it takes a certain personality to be able to have that conversation. And not everyone has that personality. And yet most physicians through their career will have to do it one way or the other or avoid it. And that's unfortunately what happens. So when I was in training, they identified that about me, and I got this extra training where we had these it was amazing. They had basically like actors that were trained on how to talk about this stuff. And we would be in this one-way mirror and they would watch us navigate these conversations. And I thought it was silly because it's weird for me to talk to an actor, but they trained these folks so well that the conversations, they would record them, then we would look at them, and it really was very useful. You realize that the conversation is not the hard part. It's almost the words you use. There's certain buzzwords that make it more serious or less serious. There's certain phrases that really paint a picture and don't allow room for fantasy, because so much of what we're dealing with is like really hard truths, and it's the phrases and the language. And that was taught to me, so maybe I have a knack for it as a person, but for sure it was that training. And then I was taken subsequently after that, there were some really amazing oncologists and palliative care providers that I then rotated with and listened to what they said. I didn't so much need them to learn to communicate with patients because that was natural, but just the phrases. And I could just see like the way you describe prognosis or the way you tell someone frankly what's going on, it changes the course of the conversation. And I know you saw that as we were talking with our patients, so we can get into some of that, but it definitely comes down to very nuanced language that ends up being the difference between a meaningful and advanced care planning conversation and sort of one that doesn't accomplish anything and everyone just feels weird at the end of it.
Right. Yeah, that makes so much sense. Do you want to give a little bit of extra attention to certain phrases that you think are key to convey, or how do you?
Yeah, let's use the most poignant example.
Okay.
So this is about prognostication, right? So every conversation ultimately leads to, hey, doc, how much time do I have, right? And oftentimes they've heard usually like a variety of prognosis. Hey, you've got 2 weeks. Hey, you've got 6 months. Hey, I don't know. It's like everyone's got a different approach to it. So in end-of-life care and hospice care, we talk about prognosis in this way.
Okay.
Hours to days, days to weeks, weeks to months, months to years. And I always tell families, if a doctor says something more specific than that, they've never really done hospice or end-of-life care, because none of us are God. No one is following some blueprint of a disease trajectory. Now, there's caveats, of course, like everything. So like, a pancreatic cancer diagnosis is pretty terrible and the prognosis is really bad. Weeks to months usually by the time we make a diagnosis. Then there's like other situations where you can say, look, looking at all the research for this diagnosis, let's say you have a dementia patient, an Alzheimer's disease patient that broke their hip. Well, we have a lot of research that suggests that once that hip fracture occurs, your prognosis is less than 6 months. In reality, and so that qualifies for hospice. So another point would be that hospice is where the doctor says that your prognosis, if the disease progresses as expected, is less than 6 months. If the disease progresses as expected. And that's the subtlety. So when you create rules, like Medicare creates rules or insurance company create rules, they have to create some kind of benchmark. And that's the benchmark. But, I've had, lots of patients that have dementia that break their hip and live longer than 6 months. Now, these aren't folks that live 10 years, right? But they can definitely exceed the 6 months. And for those listening, hospice can extend past 6 months. A good hospice agency will keep you on as long as it needs to be. And it's really up to the doctor when that prognosis changes. So I had a patient who had mild dementia, broke his hip, and, is a really close family member. And I was like, this is a bad prognosis. We're going to put him on hospice. Well, once we initiated hospice, there was so much improvement in his overall home care, even though he couldn't get into a clinic, that his prognosis extended. Now, a year after I discharged him from hospice, he ended up declining. We readmitted him to hospice, but at that point, family was ready. Patient was ready. His dementia had progressed. We had advanced care planning discussions. We knew exactly what he would want when that happened. So We reinitiated hospice, and he transitioned with his whole family sitting at bedside in his room, surrounded by love and affection and things that are, make him feel good. And yes, even if you have dementia, being in your home makes a huge difference. And we know that from robust research. So there's, of course, outliers, but that's how we do it. We admit people who we think have a 6-month prognosis or less. But when I tell families that, I always leave wiggle room. So I never say 6 months. I never say 2 weeks. We just don't know. I set up that expectation, and then I say, well, look, anything can happen and change this. So if right now it looks like it's a months to years prognosis, if we get another complication, that might change to days to weeks. It's hard to predict.
Is there a maximum to the amount of care that someone can be on hospice? Like this example you just provided, that was someone who had it, maybe was on it for 6 months, then there was a year break and went back on hospice. Does the counter then start again, or is there a maximum to, you could only have a year, or
Well, the question is twofold, actually. Okay. One is how much reimbursement is available from Medicare, and two is how long will a hospice keep a patient on? And those are two different questions. Okay. So there's 6 months of hospice benefit that's paid, actually sometimes less, but it's a very significant amount. Now, there's agencies that I think are not doing a good job when the patient gets to 6 months and no matter what, they discharge him or her. That makes no sense, because now you've collected all the monies and discharged them, and that's not right. Now, there's patients that are in critically bad situations, and because of all the hospice services, they continue to live. And I've had patients on hospice for 2 or 3 years. Is there a hard out? Look, it comes down to the medical director. Every 2 months, we're reevaluating. We're doing meetings every 2 weeks. Part of hospice is doing these IDGs, which is every 2 weeks, all the team members sit down and discuss all the cases. And that's where we discuss what can we do better? What does the patient need? Should they stay on hospice? Should they go? And then every 2 months, a face-to-face visit is done by a doctor, and that doctor gets the opportunity to say, yay or nay to continue. Every situation is different. I would say after about 18 months, if the patient is not declining, it's hard to justify keeping them on hospice. Sometimes it's 12 months. Sometimes they improve and it's actually sooner. And sometimes the decline is there and it's so slow. And without hospice care, they would just die. And you just don't discharge them until they pass. And if you're doing a good job and they're living longer, you shouldn't be discharging them just because some magical number occurs. So I think it's a very dynamic process, and every hospice is different. And I think every patient is different. So there's a whole system of financial reimbursement that's very complicated and past the scope of this podcast for sure. But a good hospice agency will be able to balance their short-term patients and their long-term patients. You have patients that come on service and die in 2 days. There's a credit that the hospice gets for the remainder of their benefits. And if a good hospice is watching their patient load carefully, they're balancing their long-term patients and their short-term patients. And the system, Medicare, it knows that. It knows that you cannot predict all this stuff. So the system is built to provide both long and short-term care. It's meant to provide enough reimbursement for a hospice to be able to provide nursing services, LVN, like a lower level nursing, shower aides, medical aides in the bedside, bereavement counselors, volunteers, social work, and physician services. So it's an all-encompassing multidisciplinary team that addresses medical issues, psychosocial issues, and even care navigation, like the stuff that you do. And so a good hospice has a nice balance of both. They're not discharging patients once they collect all their monies. They're discharging them appropriately. And most importantly, they're accepting them back when it's time to get them back. And not to get into all the scams that can happen, because there's a million ways to fraud the system, a million ways. If you just think about what I said, there's doctors can do weird stuff, nurses have families can do weird stuff, owners can do weird stuff. So, as a board certified hospice medical director, my job is to keep everything honest.
Right.
It's not about being a police officer and like scolding people. It's just like, do things that make sense, understand the rules, understand your patient's needs, and everything falls into place.
Yeah, that's great. Super helpful. I was wondering if you can also explain to me and the listeners what the distinction is between palliative care and hospice. Because in my understanding, when you are on palliative care, you still have access to doctors, but you're mentioning that still even in hospice you do,
yeah.
which is not what I understood. So it would be helpful to better.
A lot of it is semantics,
Okay.
and people will disagree with this, but just take this as my perspective as a hospice doctor. So palliative care and hospice share in that they're the same in that the goals are symptom management.
Yeah.
Okay. The difference between palliative care and hospice is that patients will continue to receive aggressive treatments on palliative care.
Okay.
So they could be receiving chemotherapies. They might even be going to surgery. And the palliative care team is sort of an extra layer on top of all of their medical care that provides symptom management. Oftentimes it's pain management, bowel regimen, nausea medicine, or just caregivers in the home.
Okay.
Now, so again, there's two distinctions here. One is what is actually in practice, and one is the financial part, because these are all businesses, even if it's a mega corporation. It's all about money. And at the end of the day, the healthcare system is financially driven.
Totally.
Number one. Sorry, it's not just patient care. It is money.
Yeah.
So the distinction in the clinical practice is mostly that they're still pursuing aggressive care. So they would still be seeing their oncologist, or still be seeing if it's a bad case of Parkinson's, their neurologist. Now it gets weird because you could have a less than 6 month prognosis, put on hospice, and you could still see specialists. You really can. It's discouraged, but hospice does not preclude other care. Now, if you are on hospice for cancer and you go see the cardiologist, going and getting a catheterization where they put a needle in your arm and go try to put stents is not consistent with comfort care. But going and seeing your cardiologist because you have known them for 30 years and you really count on them for management and guidance, you can still do that. There are modifiers to the billing codes for doctors that are seeing patients on hospice that still gets them paid. Now, you just have to be not fraudulent and honest about what those doctors are doing, right? And some doctors don't even know that that's called the GW modifier. You add that modifier and it's telling Medicare, hey, patient is on hospice, but they're seeing me anyway. And we're still doing a comfort care approach, but I'm going to manage the blood pressure meds, or family really needs guidance on what to do with the fluid status. We're talking like a cardiologist. Sure. So that still can happen. Is it useful? It's not really useful 90% of the time. It's more for pacifying families and patients to know that they're not losing their doctors. Now, palliative care is a non-reimbursable service. So it does not get paid. So agencies and medical organizations that provide palliative care do not get paid. What it is for them is a feeder system. If you put someone on with pancreatic cancer for palliative care and they're still going to go get radiation or chemo, eventually it fails. Now, palliative care programs might bill under a pain medicine service. So while they call up palliative care, they actually have pain medicine physicians managing the opiates, and they'll bill the insurance as a pain medicine management bill, but they're not billing palliative care,
Right,
because
right.
the reimbursement system is for hospice care.
Right, I see. Okay, but then is there also a incentive for the caregiving organizations like a City of Hope or Cedars to not actually discuss that the level of treatments that they've received are really not curative at this point, right? I mean, they're not going to discuss that.
They should.
Yes, but
We know in clinical practice they don't.
yeah, yeah.
So, without trying to get into their business, yeah, if you're an organization that makes its bread and butter on providing cancer treatment, if you discharge everyone to hospice,
It's
you're
yeah,
that's not. And again, a city of hope, that's really not their prerogative. They're here to give you hope and give
right.
you more time. So,
Yeah,
if a particular treatment might buy you a week or two, but cost you, terrible nausea, vomiting, and that, it may not be so clearly discussed. And yeah, those doctors and that agency, they're interested in providing you the treatment that they provide.
sure.
I also say this, and take this, guys, with a grain of salt, because it's just true, but it's sucks to hear. When you go to the candy man, they give you candy. They don't say, no, you have rotting teeth, I'm not going to sell you this candy. They would go out of business. So if you go to a surgeon, they're going to try to offer you surgery. If you go to an oncologist or a place like City of Hope, guys, is like a giant hospital here in Los Angeles that really focuses on cancer treatment, and they deal with the toughest cases ever and oftentimes impoverished people. So they're really, they provide cancer treatment.
That's right.
So they're not going to aggressively say, look, ma'am, if we do this treatment, you're going to get really sick. We know it won't cure you. Maybe it buys you a little time, but that quality is going to be poor. No, their job is to give you hope.
Right. Okay.
And they're going to treat you,
Yeah.
and they're going to not have that uncomfortable conversation.
Sure.
Maybe some of them will. It's so practitioner dependent too. I would never work there because I feel strongly that most of our interventions cause more harm than good. But I'm also not a cancer doctor, and I don't save people's lives with cancer treatment. So they're going to have a very different perspective.
Sure.
And I'm good with that. Like, we all need to respect, like, I very much respect what you do. You respect what I do. And so I want to take that to the rest of this place. Like, I am so grateful for my OB-GYN colleagues for what they do, because that is a part of medicine that's hard for me for a lot of personal reasons. It's not something I like to do. It doesn't bring me joy. And even if I'm good at it, I'm just not going to do it. So I have really amazing OB-GYN staff that I refer to, and they're awesome.
Perfect. Great. Let's switch gears. I would like to go into understanding better what the most important factors are of an advanced care plan. What do we consider? What would you bring to the table?
Yeah. It starts with, what are the goals of care?
Okay.
Everything starts with goals of care.
Okay.
When we did our talks, I probably said that word like 20 times, right?
Yeah.
Because I am not saying, this is your prognosis, this is what you have to do. That is not my job. My job is to say, what are your goals of care,
Yeah.
so that I can meet you where you're at, so that I can understand what you want and what your needs are, and then I could be a guide.
Yeah.
And so goals of care start with code status. I actually start with code status. Some people do that later, but to me, that's the most important part, because it makes it serious. It makes it real. So what is code status? There is basically a form, pulsed form, and this is a national form, and it's this one pager that says, if you are incapacitated, if an emergency happens and you cannot make medical decisions, your heart stops or you stop breathing, what do you want us to do? So we'll go through the list. So there's full code, do everything.
Right.
Then there's DNR, DNI, do not resuscitate, do not intubate.
Right.
Resuscitation means chest compressions, electrical shock, and medicines to maintain blood pressure.
Right.
Intubation means getting a tube down your throat and ventilating mechanically. So taking over the work of breathing and then actively reactivating the heart. Those are the two things. So those are the most extreme things we can do.
Yeah.
And then in between, and so I said, like, that's like the top and like the bottom, right? And then in between, there's these other interventions that we ask about. So those are, would you want IV fluids? Would you want IV antibiotics? Would you want a feeding tube, which is a tough one? Those are the main ones. And then there's something called an advanced directive,
Yeah.
right? And that is a way more like 5-page robust, like, what would you want? What do you want to do with your body? What do you want to donate your body to medical science? Do you want, it goes into great detail. I encourage patients to start with the pulsed form because that is the basics in an emergency, what happens. That then tells families, no, I wouldn't want aggressive stuff. If
Right.
I can't breathe and I have end stage cancer, leave me alone.
Right.
Or if my dementia gets so much that I can't make a decision, do not put a feeding tube in me. We know feeding tubes and brain disease is a really bad thing. I don't want that. Or do everything. I don't care how sick I am. I want to live as long as humanly possible.
Right.
And that might be someone's prerogative.
Right.
And then with the advanced directive, and that gets into more and more and more subtleties and details about everything. So start with the pulse form discussion, understand the goals of care, then get into the advanced directive.
Okay, so this was the code status. Now we're moving in towards what?
Detail. So power of attorney.
Yeah.
Who makes? There's a power of financial and there's a power of medical.
Okay.
So who makes your medical decisions?
Yep.
Who makes your financial decisions? Who takes over your estate? If those people are not available, who are the backups?
Yeah.
Like stuff. What do I want to do with my body? It's such a robust form. It's basically your death plan. And I encourage anyone listening to this, you just go on Google, you ask for POLST, P-O-L-S-T, that's the basic form, and then advanced directive form, and go through those questions, and you guys will understand all these nuances and details.
Great. That's a wonderful resource to
Yeah.
have. Yeah. Okay, and then do you have discussions with the person that is nearing the end, how to plan for that in terms of saying goodbyes to people, or how do you do that?
Yeah, it's a great question. I think I introduce advanced care planning early so that that part of the conversation is easier.
Yeah.
I talk about initiating hospice at an appropriate time so people have time to get their affairs in order. People have time to bring in families, because so much of the time, if you wait too long and then it happens, families are across the country and don't get a chance to come.
Yeah.
And that's really sad. We talk about, writing a letter to your kids, to open in 10 years. We had that case because if you're, have young children, maybe you want to say something to them on their wedding day.
Yeah.
I bring up, I really focus on, when I'm done with this conversation, you guys discuss what you discuss what you want to your family, because they're going to make those decisions if you can't.
Sure.
And be very clear and transparent about it.
Okay, that's very helpful. In terms of the family members that may have more difficulty, do you provide any sort of support for them? Because this is very difficult for them as well.
I would say more than half the time, the conversation's with the family.
Right.
Most of the time, patients are so incapacitated, they're on drugs, or they're demented, or they lack insight. Even if they're not demented, they lack insight into they could be like, just ignoring it, So oftentimes I'm speaking with the families and I'm guiding them like, this is what's going to happen. Some of these things we know what's going to happen.
Yeah.
Prepare for it.
Yeah.
What questions do you have? It's actually, most of the job is counseling families.
Yeah, interesting.
We've had a few cases with some younger folks, so that ended up being more counseling the patients themselves. But look, most hospice is not younger people, it's older people. Our geriatric population is very big and it's very sick. We have a very sick population of older people.
Yeah.
Our population in general is only getting sicker because we are living a bizarro life.
Yeah.
So most of the time it's like a 50, you got a 70 or 80-year-old lady or man, and I'm talking their 50-year-old kids.
Yeah.
And oftentimes they never even thought about it. They never even talked to them.
Yeah, it's very, very prevalent, this type of
Yeah.
thinking about it. I last year had a dear patient who found herself at this end stage. It was also pancreatic cancer. And she was receiving care of a care provider who happily handed her 2 quick appointments and a package to initiate the end of life, which is another
Medical aid in dying or hospice?
medical aid in dying.
Oh, we'll get into that.
Yeah,
Okay.
yeah, but I'm bringing this up for another reason. It's part of how they operate. They're very happy to do that. But she found herself alone. Her sons were not supporting her in a way that she felt comforted. She was a widow, and she was very, very scared. And had these conversations with me, and they had not initiated any real. They had some hospice, but no one was having the discussions with her. And so for me, that was very difficult as well. I didn't know how to handle it. So what I ended up doing was bringing up videos where people have done these great interviews and discussions about near-death experiences and how beautiful they are. And I sent her some links, and she started watching and listening to them. It was a tremendous support for her. So I don't know how you feel about that. How do you go about calming someone down about the actual dying process?
Okay, well, a couple of things. So, first of all, if a provider hands someone information about medical aid in dying and they haven't initiated hospice where you have a social worker, a chaplain, a physician, a nurse having these conversations, it's a huge disservice. So if this lady was on hospice and these conversations didn't happen, the hospice failed her.
Yeah.
Hospice is not just providing drugs and a nurse to show up. It's a full team to guide. And that's the reality is, and people are listening across the country, maybe in other countries,
Sure.
it is just all over the place. So what I do here in Los Angeles is I have a team of board certified physicians, and we take pride in being actively involved. There's some cases where everyone gets it and we don't have to do anything. And there's some cases, like I just have one meeting next week, where there's 7 siblings and 2 of them get it and 5 of them don't get it. And the family member's demented. And I'm like, we're sitting down, everyone get on the call. We're all having this conversation. It needs to happen. We need to all be on the same page. This sibling knows and had the conversation. You guys aren't listening to this sibling. You need to listen to this sibling because they know what mom wanted, and that you guys need to listen to what mom wanted. That is the rule in end of life care is you do what the patient wants or would want, not what you want because you're guilty that you haven't seen her in 5 years. Right. And we see that all the time.
Right.
It gets very selfish and weird when people are approaching death and no one has addressed it. So frankly, the answer is change hospices and have those advanced care planning discussions.
Okay.
Get a doctor like myself, get a really good nurse, get a social worker. Any one of us can do it.
Right.
I have multiple agencies, and the different agencies, it's all a mix. I have one where the chaplain he's so amazing. I'd rather have him do the conversation. As good as I am, he's incredible. Right. And so he leads, and then I jump in when I need to.
Sure.
I have other agencies where the nurses are really good, but they're not good at those conversations. So, it's easier for me with the medical side because they're like, hey, we know that. But then I need to step in and do those meetings. So it's always different with different teams. And I think that's how it should be, right? Because you're also treating different communities. And there's certain communities that really don't want to have that conversation. They're like, we get it. Don't talk to us about it. We'll just wait for the end. Yeah. And I respect that. That's cool. As long as, there was some acknowledgement of what we're doing and they understand what hospice is and they understand prognosis. And if they acknowledge that and don't ever want to talk to me about it, good. That's fine. You guys, everyone's different, right? Yeah. So that's kind of like what I think about with the conversation. If those conversations aren't had and you hand someone a packet for MAID, bad. I don't want to say malpractice, but it's bad. It's unacceptable to me.
Yeah.
Now,
if you need it, we can work this out. And I mean, I basically said something to that effect, but that was before I even met you, and that I knew how we actually do this in a much more mindful way, and that you can facilitate most of what is actually needed without having to go there at all.
Absolutely.
And so that is really the goal, in my view, unless there are certain circumstances that the patient themselves choose. No, this is how I want it, and then okay, we have to respect that.
Patient choice. I mean, and patient empowerment. I think when we did our last assessment, that was It was we could bring it up. We'll protect but this is a patient in her 30s with end-stage metastatic cancer. Still clinically, when you look at her, looked pretty good.
Yep.
But clearly with a terminal less than 6-month diagnosis, there's no question whether she could make it a little bit longer, maybe, but there's no question on that case. Very smart, very sweet, very sort of intelligent and self-aware young lady, lovely parents sitting next to me. And, when I go into those situations, the first 5 minutes, I'm sort of deciding which way do I go? What do these people need? Again, meeting them where they're at. Is it the family that's resistant? Is the patient uneducated? Is there a fear of hospice because of lack of information? Is there no one's ever said it before, so I've literally got to start from stage one. So it's like there's this moment of sussing it out, And at least in that case, I realized this is a very powerful person sitting in front of me in a terrible situation, and I want to empower her. Yeah. So I think most of that conversation was just giving her facts and feeling like you're in charge. You're the boss. This is your life. This is your end of life, and I'm here to empower you. I'm not going to tell you what to do. I'm going to tell you what you can do. I'm going to tell you what I think will happen.
You did an excellent job. That was extremely helpful for everyone involved. So
it was a good one. It's it's interesting because people always say, "Oh, you have such a heavy job." I do. It's heavy. I walked away feeling sad. I think if you do hospice and you put up too much of a guard, you're not going to be emotionally available.
Sure.
But if you have no guard and you walk away crying from every case, that's bad too because your mental health will suffer. So there's definitely this balancing act I do. And I think all of hospice providers have to do this balancing act. But that's our job. Our job is to be emotionally available, but intellectually controlling that emotional state. And I think that there's absolutely no education for physicians. So again, while you guys have heard me on this podcast harp on my colleagues, it's not the colleagues. People have the best intention. It's that the medical system wants them to deliver cancer treatment. They want them to deliver surgery. They want them to prescribe drugs. Money is made on the treatment of disease in healthcare.
But it's also people not wanting to discuss death, and that's another piece. There's a couple clients that I attend the consultations with their primary care physicians with, and this particular doctor is mostly caring for the elderly, for seniors. And he refused to even touch upon the question. He wouldn't answer the question. He says, "No, I only deal with making you live as long as possible. I will not talk about it." Yeah. So, that's hard because it left my clients very left alone and how do I navigate this? What do I do? So I was like, I will find you answers. We will work this out.
Yeah.
But
amazing that you do that. Yeah, I don't, personally, because I never was that person.
Yeah.
I was the opposite.
Yeah.
So I don't fully get them, but to try to see through their eyes, one, our training is to extend life.
Right.
Right. So our training is not for this. Two, doctors are people too, and they may have their own personal convictions. Yeah. I can speak to, for example, so I'm Jewish. I'm not religious. I believe in God and I believe in the spirit world. I believe religion is very important and powerful. Just not. I don't prescribe to like one kind of ideology, whatever. But I'm very familiar with the Orthodox Jewish community, and in their ideology, God decides when someone dies. When they become doctors, their prerogative is to do everything possible to extend life as long as possible. And when you get to an end-of-life care conversation, the decisions are deferred to the rabbis.
Right.
And the rabbis are often in Israel. They're like the head rabbis that make those decisions. So even like the local rabbi will defer out to their head rabbi in Israel. And these people are not there. They're not making medical decisions. They're making ideological decisions. So I bring this up because You might be talking to a doctor whose ideology and beliefs are in line with that. And no, they're not going to have that conversation. And I think that's okay.
Right.
Now, do I wish doctors could leave their baggage and their life at the door and just serve the patient in front of them based on their needs? I wish that was true, but you can't. You can't impose that on doctors either. So everyone has their comfort zone. If everyone did what I did, I wouldn't have a job probably, at least not the business that I've created that services hospices.
Yeah.
So I benefit from that on some level, but also I think regardless of ideology, there is a genuine fear of death.
Yeah.
Death in America is this thing we pretend doesn't happen. It happens, and then we forget about it. And I know that because I watched the grieving process. The grieving process is not honoring the dead. It is not celebrating the life that was there. It is being sad and then forgetting. And I know that's hard for people to hear, but I've dealt with thousands of cases at this point, and that is by far the most common thing. So one of the things I also counsel families on, back to that earlier question, is especially when it's an older person, especially someone in their 70s. If life expectancy is 72 to 75, if you got there, my advice is to be grateful, to celebrate life. And there's cultures around the world that celebrate death because it's part of life. Yeah. They spend, instead of sitting there and feeling sad for a week, which is like what the Jews do and Armenians do, and a lot of cultures do this like sadness moment. There's other cultures that are a little bit further away from the Western world where they celebrate death, and it's a celebration, and it's a time of gratitude, and it's a time of remembrance, right? I try to bring that perspective to anyone that will listen. They don't all listen. It's very hard to hear this part, but especially if it's an older person, I always say, this is not so sad. It's easier when they're 90 plus. Yeah. Most people will take that guidance more easily. It's harder when they're 71. Sure. And they're right on that line. It is hard because that's still, potential to live a lot longer and yet not. I don't tend to make that recommendation with younger people. I tend to focus on what you can leave behind, right? And that we had another case, a gentleman in his 40s. It was a tough case for me because I'm very close with the whole family, as you were. Yeah. So it was a tougher case for both of us because we were both emotionally invested. But I left that at the door, and I went in and I did my thing, and I sat with teenage sons, very young wife, very young patient. And my whole thing was, this is happening. There's no avoiding it. What do you want to the patient? What do you want? Tell your family what you want and prepare now for the inevitable. Call your friends, call your family, write your letters to them. That's where that story comes from. Do all the things that you can and prepare. Yeah. And then it's the opposite. This is awful. This is a bummer. Let's get ready to deal with it. Yeah. I've got resources. I got psychotherapy. I'm here. Let's do a follow-up. And sometimes, like in that case, it was like, I need to be left alone from you because I was part of it. I am now a reminder of this tragic thing. I was literally the shepherd to the afterlife, right? Yeah. So I don't take that personally. I'm like, I get it. I showed up at the most critical moment. I did this thing to help you get through it. And now you don't want to see me for a while. Yeah. I probably wouldn't want to see me either. I said some really tough things to hear. Yeah. And then later we'll reconnect, and that's okay. Yeah. And that's pretty typical with younger cases. Yeah. So
that makes sense. In closing, I would like to know from you if there's any aspect of the care that you provide that we haven't discussed, that's not even on my radar.
Yeah. So in the world of end-of-life care, there's an overwhelming amount of research that says psychedelic medicine can help people accept death. This was specifically done in the world of psilocybin. Yep. While I don't currently provide that, I am a giant proponent of it, and I'm working. I have a team in New Mexico who just legalized psilocybin for medical use, the second state, I'm pretty sure that
Very
did that.
good. Yep.
I think that's the future. I think like when I provide comfort care, I don't have anything that makes someone feel a sense of acceptance or feel good, actually. I don't have like a drug that will make you feel good. And I think that's weird. So one of my qualms with the pharmaceutical industry is that most of the drugs we have are suppressive, sedating downers.
Yeah.
When we treat depression and anxiety, the drugs we use, for the most part, there's some not, but for the most part, are suppressive, sedating. There's some stimulating drugs like Wellbutrin and Caplyta and stimulants, but they're not euphoria inducing, nor are they spiritual. So we know that there's a whole world of medicine that engages the spiritual world.
Yeah.
Psilocybin, on some level MDMA, though not necessarily friend of life because it's a stimulant, but I'll mention it. There's also like ayahuasca, DMT. There's more. Those are probably the buzz ones that people want to hear. Marijuana. I should also say THC.
Yeah.
So I do use THC. It's sort of like a recommendation, and then the families have to go buy it because of the federal laws. If I prescribe it and I'm getting paid by a federal organization, I'm breaking their laws. So it's more of like a recommendation, like, hey, you don't want to take high dose opiates, but you can take this THC CBG product, which really helps with pain. And probably you guys don't even know what CBG is. Look it up. It's an amazing cannabinoid that really helps with pain and is finally getting the attention it deserves. And you can find those products now. But then, the dream is that someone is at the end of life and you could give them psilocybin and they can have a godlike, a spiritual experience that will help them with their emotions and their feelings and help them accept death. And I think that that is something that's missing. And I think it's essential that we bring it in. I think that we should stop fearing psychedelics. We should stop fearing these non-pharmaceutical drugs. I think there's a lot of fear because those drugs are not supported by the pharmaceutical industry. And just understand, they're not supported not because they're dangerous, but because they don't make them money. The drug war, I'm going to go a little deep here. Don't get mad at me, everyone. The drug war was not about protecting people from drugs. We have prescribed way more drugs since the drug war started in the 80s than people were taking in the 60s and 70s, okay? The drug war was about two things, money and power.
That's right.
And sadly, it took away tools for decades now. It's taken away tools that could be critically helpful for people. Now, we know MDMA is helping people with PTSD. I know that psilocybin will help people with end of life and depression and anxiety and all sorts. We know that ayahuasca has been used for thousands of years and gives transformational experiences. And there's a study from just a few years ago that people's had such amazing responses to it. And just because it's a South American tradition, ritual that no one can financially monetize, people want to poo-poo it or say, oh, that's just for rich foo-foo people. It's like, no, these are real therapeutic modalities that are not convenient to make money on. And they open up people's minds, which makes them less inclined to just listen to governmental authorities. So it's not, LSD was not so much that it was dangerous. It made people open their eyes, and they didn't want that. Right. Now, whatever, some people are like, oh, what are you talking about? No. Tons of books have been written about it. I've done podcasts about it. None of this stuff should sound weird and the government knows this and everyone knows this and it's okay.
Yeah.
Stuff happened and we can't go back. Right? What we can do, though, is wake up and go forward and say, it's not that the pharmaceutical industry is bad. They're just an industry of business people and scientists trying to create therapies and make money at it. It's not that psychedelics are the magic end all. It's just that they're tools that are not currently available to us. So we need to all take a thoughtful, logical approach to it so that we can deploy these things in the end of life care setting. We could deploy these things in the psychiatric setting. We could give people opportunities to reconnect with their spiritual, emotional side or work through the dark side of their past and not just fight about pharmaceuticals are good or they're bad or psychedelics are good or they're bad. It's not a nuanced conversation. This is a nuanced conversation. And it's worth bringing up because it's a tool we need in end-of-life care. And I hope that in my career over the next 10 or 20 years, it's a tool I'll be able to use.
Yeah, I hope so too, because it seemed to really useful for many people, and all of the papers that have been published on it. We like to have that available.
We would like so.
Yeah.
We'll see.
Yeah. Super helpful, all of this. Thank you so much, Gary.
Thank you,
Appreciate it.
Petra.
Yeah.
Guys, it's a heavy conversation. We're going to leave it at this. So we wanted to kind of share our conversation. Me and Petra really wanted to have this talk personally. And I'm like, why don't we do it for people to hear? Because it's everyone needs to hear this, whether you have a dying family member, you're going through it yourself, or you just want to understand this world so that you're not so, caught off guard when the time comes. If you guys have questions, hit me up on Instagram, drgaryevolve. Petra, is there any way if someone wants to reach out to you, they want your guidance, they want your services? Do you have a website?
I have a website. Yeah, it's drpetrad.com.
PETRAD.com.
Yeah, DR in front of
DR, Dr. Petra.
Yeah.
Okay, well, hopefully we'll have you back. We can talk a little bit more about some of the other fun topics. But for now, thanks everyone for listening, and goodbye.